All right. So my first case is a 50 years old male who complained of metamorphopsia and scotoma in the right eye for 4 weeks. On examination, his vision in the right eye was 20/25 -1. Fundus examination revealed a neurosensory detachment at the macula. Left eye was within normal limits. This is the fundus photograph showing neurosensory detachment at macula, fundus autofluorescence showing hyperfluorescent areas in the area of fluid, fluorescein angiography showing a smokestack leak in the juxtafoveal area superior to the fovea, and the OCT showing neurosensory detachment and underlying PED. Subthreshold micropulse laser was done on the same day using Navilas system with 577 nanometer wavelength and 5% duty cycle. This is the baseline OCT. And at 4 weeks, we see that the fluid went down. At 8 weeks, it went down even more. And there was a complete resolution noted at 12 weeks. The fundus photograph shows some subretinal fibrin deposition, which is seen on the autofluorescence as well. And the visual acuity was 20/20 at 12 weeks. So the rationale for early treatment was that fluid accumulation under the retina at the acute stage leads to a certain amount of damage to photoreceptors, which seems to persist even after the fluid is resorbed. This results in decreased contrast sensitivity, which can be permanent. Studies have shown that in central serous chorioretinopathy, outer nuclear layer thinning starts an early stage and may continue as long as the SRF persists. And studies have also shown that for treatment of chronic CSC, laser provided good morphological results, but there was no significant improvement in visual acuity, and that was attributed to outer retinal atrophy. How soon should the eyes be treated? We did a randomized controlled trial, and we divided the eyes into 2 groups, laser group and observation group. We included eyes with duration of symptoms only less than 2 months for single active angiographic leak that could be at subfoveal location, juxtafoveal, or extrafoveal. Fluid should have been present involving the fovea on OCT, and it should have been the first episode of CSC. This was done on Iridex using 810 nanometer infrared diode laser at 15% duty cycle. The duty cycle was 15% because the study was approved actually before 2013. And so by that time, 5% duty cycle papers had not come out. We saw that the visual acuity improved in both the groups significantly 2 weeks onwards, but it was better in the laser-treated eyes 2 weeks onwards. In terms of contrast sensitivity, it improved in both the groups, but contrast sensitivity was better in the laser-treated eyes 8 weeks onwards. Height of neurosensory detachment, it improved in both the groups 2 weeks onwards, but there was a faster resolution in laser-treated eyes starting at 2 weeks. In terms of choroidal thickness reduction was achieved in both the groups 2 weeks onwards, but the reduction was more in laser-treated eyes at 8 weeks onwards. Recurrent or persistent neurosensory detachment was observed to be 11.76% in laser-treated eyes versus 29.41% of the eyes which were observed at the end of 6 months. Despite the 15% duty cycle, no laser-induced iatrogenic damage was noted in any of the eye that underwent laser treatment. This laser, micropulse laser, has a very high safety profile and should be considered in acute central serous chorioretinopathy and in cases where the angiographic leak is at subfoveal location. Faster visual rehabilitation, better quality of vision in the long term, and lower recurrence rate are the advantages. Here are some more papers which demonstrate that using different wavelengths, a micropulse laser is beneficial in treating the acute central serous chorioretinopathy. My second case is a 36-year-old female who presented with metamorphopsia and blurred vision in the right eye for 6 months. On examination, her vision was 20/25 in the right eye and fluid was seen under the fovea. Left eye was normal. This is her OCT showing shallow neurosensory detachment involving the fovea. This is the ICG angiography and fluorescein angiography showing a small leak present slightly inferior to fovea. Micropulse subthreshold laser was done on Navilas at 5% duty cycle, and the entire area of subretinal fluid, including the fovea, was covered. At 6 weeks, visual acuity was 20 by 20 and a complete resolution of fluid was noted. Safety of transfoveal subthreshold laser has been shown in many studies. So as far as the area covered is concerned, when it's in acute CSCR, the area to be covered is the focal area of leak and the adjacent area. But in chronic CSCR, the focal area as well as the areas of diffuse hyperfluorescence should be treated. Recommended, as mentioned earlier in the earlier presentations, is recommended at 2 to 3 months in case of poor response. In comparison to PDT, in chronic CSCR, it has been shown that half-dose or low-fluence PDT is the accepted gold standard for chronic CSCR. Place trial even compared half-dose PDT versus subthreshold micropulse laser and demonstrated PDT to be more efficacious. Another study compared half-dose PDT with subthreshold laser in chronic CSR and concluded that micropulse laser is an effective option for the treatment, especially when leak occurred at parafoveal or subfoveal location. Half-dose PDT is more efficacious in resolution of SRF. Now, when comparing the two in acute CSC, it was shown that subthreshold laser may be as effective as half-dose PDT in acute CSC while minimizing the damaging effect on retina. Considerations are a little bit different, especially when we are treating subfoveal cases or acute cases, and we are a little more bothered about the safety. We know that the side effects of PDT are choriocapillaris ischemia, choroidal neovascularization, and RPE atrophy. Systemic side effects also existent, and expense and availability of PDT is another issue. So subthreshold micropulse laser is a safer, effective, and a reasonable option in these cases. Now, question is, how is the structural recovery after subthreshold micropulse laser? If it's an acute CSC and outer retinal atrophy has not occurred, then usually visual results are very good. But depending on the chronicity of CSC and how much outer retinal atrophy has occurred, visual outcome is completely dependent on that. Thank you.
Thanks, Supriya. That was very interesting. I noticed that you showed very interesting cases. One was a very early treatment of CSCR as presentation, which turned out to be a great outcome, as well as a subfoveal or transfoveal treatment for central serous. And I think that is a very clear message that subthreshold laser is safe and we can easily repeat, and that is where, at least in our opinion, it is superior to PDT because there are no structural damage reported with subthreshold laser, so we can safely repeat. And as you correctly said, that PDT is unavailable in many countries. And I see Pradeep has a question. Please, Pradeep.
Supriya, there's a great cases and great talk. Couple of questions for the case, the second case that you presented where there was a focal leak. Can you talk about what was behind the decision making to treat the entire area of SRF rather than the focal leak in the adjacent area And the second question is, when you are treating the site of the leak and the adjacent area, how far beyond the leak site do you treat?
So the second case was actually a chronic CSC. The duration of complaints was about 6 months. And we see that, the structural changes had already started coming in. So in those cases, it is recommended that we treat at the leak area as well as the diffuse hyperfluorescence and the subretinal fluid in the entire area. So the picture that I showed, wherever there is a central, around the fovea, the entire area of the subretinal fluid, we treated the entire area with that, with the laser.
Yeah, and I can just chip in here. I think, Supriya, this is the case which we discussed earlier, right? So Supriya did discuss this case with me, and I have been doing this, that, if I see a chronic central serous, and in fact, I'm writing a series now where we have a very small subfoveal fluid which has never been treated because we really don't, means people have reluctance to do PDT in those cases. But then they come to me and I usually tend to cover this whole area I know that we do their FA and ICG and we look for a leak, but just imagine that because this fluid has been there for a long time, this has caused damage to the RP. And I think doing and covering this small area usually helps a lot. So I have experienced really good outcome with this.
When you are just targeting the leak, usually you'll see a small PED on the OCT. Do you go double the size of the PED, or how do you decide the size of your treatment when you're doing a more focal? You're just targeting the side of the leak.
We would just like to extend a little bit more than the focal areas if you're talking about a focal leak. But for a case like Supriya's second case, here, if you have a shallow PED, but here, in my opinion, the whole the whole goal was to cover the whole SRF area to like somehow make difference to the RP activity. All right, I think we should jump. Yeah, lead it.
Jay, yeah, I just want to make a comment. So Supriya mentioned there the place study, and the place study is really the only study that has compared subthreshold laser and the PDT for these cases of CSCR. However, I find that there is a major flaw in the design of the place study. In the eyes that were treated with the micropulse laser, they mentioned they use dense treatment. However, they use 810, and 810 did not have any patterns available at that point. So as I mentioned in my talk, when you're treating with invisible spots and you do not have a pattern available, then you're not doing a dense treatment, in my opinion. And I sent the letter to the editor, the AJO, when they presented this study, and the investigators admitted that they did not have a dense a pattern available to them. So I think that they their arm of subthreshold laser suffer from under treatment.
Yeah, I agree. And another thing is that they did not extend the treatment in the micropulse cases within the 500 microns of the fovea as well. They always stayed away. Whereas in PDT, they included the foveal area.